Fine. So nice to meet everyone. I'm Piyush Mahaptra. I'm one of the lower limb surgeons here at West Herts. So Watford and St Albans. I know some of you obviously from back on my time at the rotation and from you visiting, but pleasure to meet those who I don't know. So my background is I kind of stayed local. So I was local all the way through my training. I was in North West Thames. Did all of the major units, even went south of the river a couple of times, and then fellowship locally. I've been involved, as probably some of you know, I do some digital stuff as well, which kind of keeps me busy. But really my practice is very much around DGH, soft tissue knees. So I don't do any complex multi-ligs. We just don't see enough of them. But we see a lot of kind of meniscal work. Quite a bit is on that borderline of degenerate, and what the right decision making to do there is, particularly within kind of an NHS public sector setting. It'd be great to do meniscal transplants on everyone, who thinks they're a weekend warrior at 40 playing cricket. But that's not the environment we're in. So hopefully this talk is very much a bit of an overview. So I'm not going to teach you anything really detailed. I think a lot of that is for the books. When I was in your position, I got bored to death when people were trying to tell me some random paper or some facts to try and remember, particularly around part one. So this is more around, as Mr. Gupta alluded to, the part two part of FRCS, where it's more about communication. So how do you articulate what you know? How do you articulate your decision-making process so that when you're vivaed for the station, people think that you're a sound clinician, which is ultimately what they're checking. So this is an overview of meniscal anatomy. Again, very high level. Really helpfully, this diagram is the opposite way around to all the others, just to catch you out. Most of the other ones have anterior pointing down, but this is anterior pointing up. So very simple. Kind of high level, obviously we've got a range of experience in the room, but we've got an anterior horn, a posterior horn, and a body. The medial meniscus is much more C-shaped, so you can see that. And again, I think you used to do this a lot, you used to put up a blank diagram of the knee and then ask you to sort of reference it and label it. So I've cheated and done it for you, but you can recognize the medial and the lateral side. And again, just next time you do a knee replacement, look at it closely. You can see that the medial and lateral menisci are definitely different. And again, when you're often trying to take in lots of things all at the same time, but during a total knee, that's your best time to appreciate anatomy. But it all open in front of you. Obviously, sometimes there's wear and some of the menisci are torn. But if you're doing a knee with medial OA, you can see that lateral meniscus in is much tighter a ring, and then you get discoid variants, which again I'm not going to bore you to death today. This is more about treatment and pathology and how the essentially that that circle is much more complete in a discoid, and that can have problems. But again, usually in that sort of presenting in the pediatric population, if it is going to cause issues. Right, so. What we're going to go through today, very quickly, we're going to talk a bit about anatomy and biomechanics, move quickly on to sort of classifying meniscal tear patterns, going through some of the clinical presentations, a bit around the diagnostics, which again I think is not taught very well. When I was in race training, a lot of the time it was sort of you just look for the MRI and you look for a bit of white, and so you don't really get that radiology training. And then actually, when it comes down to practice, half your time is radiology. Alluded to, most of the time you make your decisions before you've even seen the patient, not that you're meant to, so you really got to do it the other way around, but obviously sometimes pressures dictate otherwise. We'll go through a little bit around the kind of operative and non-operative steps. Again, there's not a huge complexity there. That's more about getting hands-on and learning to use the devices and the equipment, and again a little bit around decision making of what fixation type to choose in what setting. And a bit around post-op rehab and recovery. So, going through to kind of meniscal anatomy and function, you can see here there's a couple of key zones. So just so we're all okay on the nomenclature. So the popliteal hiatus, you can see on posterolateral corner. So that what's special about the popliteal hiatus? Who wants to answer? What do you see? So when you do a new scope, what do you see at the popliteal hiatus?
Obvious tendon.
Yeah. What can you do with the meniscus? Where is the tendon in relation to the meniscus? Yeah, so it's
a tear in that zone, you can potentially repair it.
Potentially, but remember it's a hiatus. So what does hiatus mean? Yeah. So that area, there's no capsular connection. So you don't necessarily, you can normally get behind the meniscus into that hiatus. So don't just think because you can get your probe behind it that it's torn. Right? It's normally not attached. That's why it's got that name. Whereas on the medial side, you've got circumferential capsular attachments. So the popliteal hiatus is just an important landmark. Again, obviously, if there's lateral tears, you can occasionally peg those back, but I tend to try and avoid it if I can. People get pain and discomfort and don't really like it. Peg it into the tendon. And then you've got your anterior intermeniscal ligament. So again, lots of people, particularly registrars, start shaving fat pads, start shaving bits of tear or ACL stuff, and then they take out the anterior intermeniscal ligament. So just be wary of that at the front as well. Try not to injure it or disrupt it. And again, next time you do a knee replacement, have a look. You can usually see it. It is pretty clear, but you don't want to go start debriding that unnecessarily. So it's just about appreciating those structures when you're looking through the knee. So this is a bit more detail. And I put this on because, again, I thought this was just the bit that people don't really talk about very much, is the meniscal attachments. So these are the meniscal roots. So, and again, you're not, I don't think, expected to look at the measurements and the individual values. So don't be too concerned about that. But look at where the attachments are in relation to the other structures. That is a bit more important. So you can see your medial meniscus, the anterior root of the medial meniscus is fairly anterior. And you can see it's quite far in front of the ACL footprint and attachment. That's quite important. So that's that big, remember that big C on the medial meniscus. And then you've got your posterior medial meniscal root, which is just in front of the PCL attachment. And you can see then the lateral meniscus almost fits completely within that. So the meniscal roots for the lateral meniscus are much more central within the knee. So the posterolateral root is actually quite medial. So it's in front of the posterior medial root. And again, you can injure that or debride that. So again, some people I've seen who you're looking at the posterior medial root, posterior meniscal root, you're sort of debriding that, or you think, oh, there's a bit of a tear there, and you actually start damaging into the meniscal root of the lateral meniscus. So again, you just got to be cognizant of that. And then the other thing is the anterior root of the lateral meniscus. You can see is on the anterior side of the intermeniscal ligament here. So you can see that it's really, again, much more posterior than you would expect. And again, you can injure it when you start doing ACLs. So there are actually a couple of companies, again, I don't know how well they work, but the theory goes because you can damage your ACL, your anterolateral root with an ACL guide. They actually came up with specialist drills and specialist things to try and avoid it. Again, I suspect that's probably more marketing than actually useful, but just beware that the anterior root of the lateral meniscus does come across quite a long way. So you want to be, again, not reaming the whole thing out when you're doing your ACL. So useful things, and I think, as I said, the roots are probably things that are not talked about as much, and they're becoming more and more recognised and more important, particularly nowadays. And there is a move towards doing root repairs a bit more commonly. So I'll go on to talk about blood supply. So this was quite an interesting, I thought they were just cool pictures, quite frankly, on the left. So this was it was published in Nature, but a microvascular CT scan, cadaveric, looking at the blood supply. So you can see, this is all stuff we know, and this is a bit that is taught very well, but you can You see most of the blood supply is at the roots and then a little bit peripherally. Giving the answer away, so I was going to ask. But the blood supply is primarily from the inferior genicular artery, and then you have kind of the lateral and medial with the branches thereof. So you can see there's that ring pattern. Again, this is things that you should just know that is very commonly asked both in part 1 and 2. And then this is it in much simpler to digest diagrammatic form. So hopefully this is not new to everyone, but the red zone, the red-white zone, and the white-white zone. And I think as you can as I'll probably go on to talk about a little bit more, there is a bit of a change now in terms of what people are trying to repair. The move is certainly much more towards much more aggressive meniscal repairs, sometimes in white or red zone. So I think that old adage of only repairing things in the red zone is fading away a little bit, and you have to judge on a few different factors. And again, that same kind of microvascular CT, you can see where blood supply comes in, again, very much peripheral and very quickly goes away. So I will ask a question here now. So how does, obviously the meniscus is a living tissue, how does the white zone get its nutrition? How does it stay alive?
I don't know, does it just diffuse through the zones? I don't know.
Yeah, well, so obviously, so the peripheral supply, but you can see they're very clearly on that CT, blood doesn't really get that far.
Synovial fluid.
Yeah, exactly. So you've got synovial fluid that will provide that white zone of nutrition. So, and again, and I will touch upon this a little bit. So this is one of the theories. What should you do when you any intra-articular injury, any intra-articular work you're doing? What's your kind of rehab and recovery protocol? I'll go into a bit more specifics later, but what's one of the key principles?
Early range of motion.
Yeah, exactly. So early range of motion. So again, the theory goes, again, I don't know how true the actual science is, but the theory goes that you're moving, as you move, you encouraging flow of synovial fluid, and again, that can help provide nutrition, particularly to intra-articular structures without cartilage and menisci. So, meniscus function. There's lots of ways you can look at this. But the clear kind of primary function is around load transmission, so 50 to 70% of your compressive load and shock absorption. So you can see here, there's some nice sort of diagrams. Essentially what you're doing is there's the femur and the tibia are incongruous. So if you think about it, the femur is a round ball, your tibia on the medial side is a bit more concave, so it does accommodate a little bit. But on the lateral side, certainly it's really convex. So, it's two sort of domes together. So obviously when you have two domes together, you get point loading. So at the apex, there'll be quite a lot of force. And this is what this diagram here is trying to show. If you don't have a meniscus, what you'll get is a lot of contact pressure at those two apices, and that will clearly cause your joint to wear out. Which is why what happens when you do take out your lateral meniscus, you get lateral meniscal OA. And this is, boils back to why it's so important around lateral meniscus is much more important. Why you want to try and preserve it as much as possible. But you can see when you've got a meniscus that's intact, you can see that load is distributed much more evenly across the entire joint surface. So that's basically one of the key functions that it has. There's clever free body force diagrams that you can draw, which again I'm not going to sort of bore you with today. But the take home is around joint stability. The menisci are often seen as your secondary stabilizers. What happens when you have an ACL tear in a child? So isolated ACL tear, why do we treat those? Than say, 35-year-old. Esther?
Guys, shout it out. You know what? Even if you say the most stupid thing,
Yeah, there's no pressure.
It's a really good idea just to start thinking around, because you won't know the answers to stuff, but you have to just think around it. And even if you get the answer wrong, it's better you shout something out. That thought process.
And this is sort of all pattern recognition, right? There's no reason why you know it until you've heard it. And once you know it, and it's the same every time. So, yeah.
Okay. Does ACL also give some rotation instability? So if you have that in a young child, they're likely to damage their meniscus while growing up. So you can get to damage.
Yeah, fantastic. So why do you damage your meniscus?
It's the meniscus are secondary stabilizers, especially particularly the medial one, the posterior root. If you do have an ACL tear, you end up damaging the medial meniscus because that's its primary root, really.
Yes,
Posterior root.
exactly. So again, that big C shape. So a lot of time people think you can think of the medial compartment of the knee as a ball and socket. So I haven't included the diagrams here, but the normal kinematics of a knee is you get flexion. The lateral side rolls back much more than the medial side, and then you get a bit of femoral rollback translation on both sides. But the medial side effectively stays relatively still, doesn't move back very much, but rotates. And the way it can do that is the medial meniscus acts like this, that big C acts to hold it in place, deepen that ball and socket. So if you lose your ACL, you get lots of kind of micro instability without kind of formal giving way. And again, in children, their ligaments are generally laxer. They're not as strong muscularly, and obviously they've got a lot longer to go. So you're much more likely to damage your medial meniscus. And you see it in adults as well. You know, you see the person who's had an ACL tear playing football. They sort of thought it was okay. They weren't particularly serious in terms of sports. So got back to playing a little bit, and then suddenly there's another pop or something happens and they got a locked knee. And they've got a big bucket handle medial meniscal tear. So in that situation, I suspect most of the time is the ACL that went, they rehabbed, and then the medial meniscal fails, rather than the other way around, which I think a few people fall into the trap of, is that, they had a meniscal tear and now they've got a bucket handle and an ACL at the same time. But the key to looking at that is to look for how much edema they've got. If they haven't got that pivot shift edema, as they've sort of represented with a locked knee, then you can be pretty sure that the ACL was chronic and they've got the bucket handle meniscal tear is new. So yeah, joint stability, really important function of the meniscus. Again, one of the key things, and one of why we're sometimes more aggressive, particularly in children, for treating ACL instability. And then the final thing is around proprioception. There is a sort of proprioceptive element for menisci, which again is obviously probably slightly less important than some of the others, unless you're dealing with kind of high-level athletes. Right, so again, a very really high-level overview on kind of the basic science. This is stuff that you can read out books, and it's really for the part one. But you can see it's all about hoop stress. So hoop stress is really important. I'll come back to that and what that means for repair and surgery in a little bit. But you can see you're compressing the axial load into hoop stress across the meniscus, which is then transferred into the capsule, and less is going onto the surface itself. You've got a transition. So what does anisotropic mean? Is that basic science? One shout out. That's isotropic, yeah, exactly. So what is anisotropic? It's not quite changes shape, but it behaves differently in different directions. And part of that is that bottom diagram here. So you've got radial fibers, you've got tie fibers. So as I said, the main point is it can dissipate those hoop stresses, and those tie fibers stop the whole thing kind of coming apart. So it's really quite stiff and rigid along that circumferential way, but on the radial direction, but in the circumferential, it can kind of expand a little bit as well. dissipate all of that hoop stress, and that's the key. And again, we'll talk about that and how that affects your surgical treatment, because if you start getting disruption of the circumferential, that's what causes problems, and you can effectively defunction the whole meniscus. And again, you've got chondrocytes, so chondrocytes are much squidgier, and fibroblasts, again, much more rigid on the outside. So again, definitely worth for part one. That gets into a very common exam question. Right, so clinical presentation. I don't think this is particularly rocket science, so I'll sort of go over it quite quickly. Obviously, people have some pain. Joint line tenderness is probably the single key kind of diagnostic finding on examination. Again, I always thought it was quite funny. You just say, does it hurt here? And press the patient goes, how? And so that's about the start and finish of your orthopaedic examination. Obviously, being slightly facetious, there are some provocative tests and other things that you can do, and look out for mechanical symptoms, particularly locking and clicking. And then I think the other big thing to think about when you're doing your history and assessing the patient clinically is what are your host factors? So, and this is more to guide your decision-making process, and particularly for part two, this is how you score higher marks. Is you're not just trying to elucidate a diagnosis, you're trying to understand what your treatment regime and modality would be. So what kind of factors might affect, so patients come in, barn door meniscal tear, you picked it up clinically, what kind of other things might you want to ask that might affect your treatment? Simple stuff.
Smoker.
Yeah, smoking.
Baseline activity level.
Yeah, including
Whether they're avid sports people.
other things.
Weight, age.
Weight and age and patient expectations. Yeah, and then and some any medical histories that would contraindicate headache and things like that, whether that would sort of push you down. Yeah, smoking, sports are probably the two biggest ones to think about when you're. And again, it shows the examiner and the people and the person that's assessing you that you've already thought about the diagnosis and you moved on to how am I going to treat this patient, what am I going to recommend to them. And this is like simple stuff, right? This is not, you don't need to actually know anything to be able to do this. This can apply to like any situation. And this is where the exam technique comes in. So types of tear. So people get really, really worked up about a lot of this. Yes, there is some relevance. I think you can go a bit over the top. Perhaps I have a slightly different view to others on that. But bottom line is you've got a horizontal tear. So that is going across, splits the meniscus in two. A lot of the time you see that in your degenerate, posterior horn. See that kind of horizontal cleavage tear. Very common. Got your longitudinal tear, so this runs kind of parallel to the loops. So again, these are quite good for repairs, and again, I'll talk about that in a second, because you can quite easily put stitches and sutures across. You've got your radial tear, which is much more problematic, and again, because you're disrupting that circumferential structure of the meniscus, and so actually you can defunction the whole meniscus if you go all the way across, and the whole meniscus can effectively become ineffective. So that is so radial tears can be a real problem. Bucket handle tears, they're fairly obvious, and you've got things like flap tears. I think flap tears basically a combination of a radial and a longitudinal, so there's just a bit more. And then obviously you get degenerate variants of quite a lot of that. So so lots of types of tears. I think obviously you've got to kind of have that in your mind, and then I think the bit that I never really got taught very well was around the MRIs. It's like how do you actually diagnose these? So you can see here this is a longitudinal tear. So if I go back to that diagram, you can see that line there, right? So that is the line that runs through the meniscus, and this is your MRI scan, what you're looking for is that white line is contacting the joint surface. So you see a lot of intrameniscal high signal, which is normal. Actually haven't included a good example of that. But this one very clearly goes to the meniscal edge. So a tear is only a tear if it contacts the edge of the meniscus, and this is very clearly a shout out the diagnosis. Next.
I think this is a longitudinal medial meniscus tear
Yeah, of the
posterior one.
yeah, perfect. Why did you say it was medial?
Because it looks more like a C shape.
Harder. You can't really tell C shape.
Yeah, I
What
know,
else?
but it's a,
You can't see the fibula.
You can't see the fibula, yeah, but the slice might have missed it. But also look at the tibia. What's the
Yes.
shape of the tibia? Yeah, so that's the key as well. You look at the shape of the tibia, and it's probably not the best slice, but oh yeah, sorry. I'll go faster. Okay, so radial tears again. You've got cleft signs here, so this is where you've got cleft. You've got the marching cleft sign where that cleft kind of moves on different slices. So you can see there that you've got a line there, and line there, and this is again all on the sagittal MRIs. You've got your truncated triangle sign, so where the it doesn't form a complete triangle, so it's just cut off, and then you've got your ghost meniscus where you can't necessarily see one of the horns, so that is bad. So you defunction the meniscus at that point. And this is your bucket handle tear. So again, this is very classical. You've got a double PCL sign, posterior cruciate, double PCL, and the double anterior horn sign. So this is obviously a big bit that's flipped over. Horizontal tears, you see this quite a lot, and this is what I mean about contacting the surface and that intrameniscal signal. So treatments. No, non-operative treatment. This is a valid option. So make sure there are good papers out there, including RCTs. So this is something that you probably should be able to quote. But good for degenerate tears with no meniscal symptoms, and they have been shown to be non-inferior. Now, non-inferior trials, obviously, they have some limitations. A lot of RCTs do show non-inferiority, so it depends on your patient cohort. But it is a very valid treatment modality in patients over 40. Everyone has slightly different algorithms. It depends a lot on patient expectations, smoking status, etc., etc. You've got to think about whether they're white on white, they're irreparable in inverted commas, and you obviously want to minimise resection. So meniscal repairs. Now again, there's 3 common techniques. There are more, but I'll stick with these for now. And the rough rule of thumb is what I've included there. So all inside for the posterior horn, inside out for the body, and outside in for the anterior horn. As I said, it is possible to do other things, but this is sort of a good guide. And again, for the exam, you just need to be able to justify and say why you're doing these. So I'll touch on these very quickly. So the all inside, you've got different equipment. All of it's orange, as you can see here. Flex is quite helpful because you can start curving it around. So out. So in theory, you can do some of these more anterior tears with that. I quite like it actually. Sometimes it's good for the posteriors anyway, where you've got a tight medial compartment you're trying to get in. But all inside devices are quite good. You just got to be careful, and this is why the sort of techniques exist, is that you're all inside your posterior horns. You are generally pretty safe, except for if you're going straight kind of back with the lateral meniscus from the lateral portal. Again, not many people do that, but just be mindful. Water, again, your peroneal nerve, you're reasonably far away unless you get really, really carried away. So they've all got stops and safes and things like that. So that's kind of the safe zones on the all inside. Then the inside out, this very good for mid-body tears. You've got specialist equipment like trocars here and long needles. Again, very cheap, cost-effective, which is why I think the suppliers probably want you to not use them as much. But they are very good for kind of mid-body tears, as you can see there. You can get a nice angle on them. And they can also be quite good for traction sutures. So if you've got a big bucket handle tear, you can put it through, pull it out, pull on it, and that actually helps you reduce your bucket handle tear. You sort of make a little cut in the skin once you pass the needle, go down, and then you can tie it over the capsule at that point inside out. And as I said, it still very considered the gold standard in terms of meniscal repairs. But outside in, again, you can get special equipment. You can even DIY it using needles and suture loops. So very good for your anterior horn, because if you think about your anterior, you can't really see it very well. You sort of have to, you can't get access, so you can essentially just pass a needle from the outside, grab a loop, grab a suture, and tie it all on. So very good for kind of anterior. And again, there's specialist kit, or there's needles and loops. The augmentation. So this is something that's now done quite a bit. There's different things that you can do. I'd recommend you probably do some of all of it, except for the bottom one. So the trephination, fairly easy. Use a needle, make lots of small holes. You're encouraging bleeding. Again, abrasions, diamond rasps. You can go and kind of rasp the meniscal edge, and you can do a little bit of microfracture on the notch. Again, to encourage bleeding. So this is why the theory goes why if you're doing a concurrent ACL reconstruction and a meniscal repair, the results are much better because you're filling the knee full of blood. But you can recreate some of those, and then as I said, you get really fancy things like PRP and fibrin clots that you put into these pockets within repairs. And then you get some other new equipment. So that, again, they're very expensive. I don't really have access to this very much, but the Nova Stitch can help you deal with some specific tears. So the way I think it is quite useful is these radial tears. As I mentioned, radial tears defunction the whole meniscus, so you can do kind of these white on whites and pull them in and actually close it up quite nicely. You can't really do that very well with other devices unless I'm doing it wrong. Then again, you can do these hay bale sutures, which are quite good again for these big degenerative tears, because you can get all the way around the meniscus. So those are potentially quite useful kind of adjuncts. And again, you can use them for your root repairs, but you can do that with fibre tape and first pass and other kits. So post-op, I don't think there's a clear consensus. It's not as far as I'm aware, unless any of the faculty correct me. The key is around hoop integrity. Most people limit flexion to maximum of 90 degrees. Some people do less for a period of 4 to 6 weeks. Again, you just often load the meniscus more. It does depend where the tear is. So obviously, most of the time we're dealing with posterior mid-body tears, so that's where you want to particularly limit flexion. And I think there is probably a move. Certainly, when I was initially training people, weren't weight-bearing people. Now I think there is a move towards weight-bearing for most. I certainly weight-bear mine fairly early, mostly in extension. Again, there's a bit of evidence now to suggest the meniscus remodels quite well. So if you're axially loading it, so I say full weight bearing in extension straight away, and then often braced for a period. Perfect. So that's me. So,
Well done.
Thank you.